SAGES and ASCRS session entitled Laparoscopic Colon Surgery Symposium, Why Aren't More Surgeons Doing This Operation? We've chosen what we hope are some fairly controversial titles and some speakers who are not afraid to invite some controversy. My co-moderator is John Marks, and the first speaker is actually John Marks, not Tom Reed as in your program. And John will be addressing, with results like these, why is anyone still doing open surgery?
All right, welcome everyone. And so really this is a matter of what we call, I would say, getting past the tipping point, the barriers to laparoscopic colectomy. This is my hometown of Philadelphia, and this is where I work. I don't have any relevant disclosures for this talk. The definition of tipping point in physics is that of adding a small amount of weight to a balanced object that causes it to suddenly and completely topple. In sociology, it is the event in which a previously rare phenomenon becomes dramatically more common. And this phrase was first introduced in the 60s by sociologist Martin Grodzins, who discovered that and it was looked at neighborhoods, and it was talking about white families remained in the neighborhood as long as the comparative number of black families remained very small, but at a certain point when, quote, one too many, unquote, black families arrived, the remaining white families moved en masse, and that was where the term of white flight came from, and he called that moment the, quote, tipping point. And this was later, the Nobel Prize was awarded to Thomas Schelling on this. And this work also led to the notion of the threshold model of collective behavior. So with this in mind, if we go back to the early days of laparoscopy, this was the 5-year forecast that U.S. Surgical expected in terms of the amount of cases that would be done laparoscopically in 1998. Colon, greater than 70%. So what's the next big thing in colorectal surgery, laparoscopic colorectal surgery? You know, what you hear is, hey, that's old news now, everyone does it. You know, is it sills, is it robotics, is it notes? And so what I would submit to you is that in this day and age, the transition from open to lap is poor. And so what should the focus be on now, I would say, is laparoscopy and really just finishing the job. So historically, and these are pulling some slides back from giving these talks in the 90s, you know, why has there been a slow transition? Well, originally it was concerns about wound recurrence, and in particular, this 21% incidence of port site recurrence, and really it was the responsibility after all the trocar site injuries in laparoscopic cholecystectomy to enter into this really in a controlled fashion. And I think that's what organized medicine did in laparoscopic colon surgery. There were certainly obstacles to adoption in the colorectal group. Many colorectal surgeons didn't have a lot of laparoscopic experience, although they'd done a lot of colon work. In the general surgery group, many general surgeons had a lot of laparoscopic procedures, but on average were only doing between 5 and 10 colorectal procedures in a year. So when you put those two things together, there were certainly challenges, and certainly ego is not short on either of these lists. So the basic math of surgery, if you take the least experienced laparoscopic surgeons, ask them to do technically some of the most difficult things, there's going to be poor outcomes and little enthusiasm, and that's what we saw for a long time. So this is a trend. This was published in 2008 in Surgical Endoscopy. This was the trend in terms of adoption of things laparoscopically, and you see this is 4% over here. And this is a gradual progression. If you followed the same slope of that curve going forward, in 2020 we'd be up to 40%. However, if you talk about things such as a tipping point, if you think of the internet as an example, it was developed in '57 as a response to Sputnik. It became something that was used in 1969 from Stanford to UCLA. In 1991, AOL published operated their system launch. And then in 1995, 1996, there was really an explosion, a tipping point. Really, we can't imagine what life would be like without the internet right now. And this, I would submit to you, is really what I think we're in that era now in terms of laparoscopic colorectal surgery. That said, of the 300,000 cases done in the US in a year, what's done laparoscopically? And really, when you look around the globe, it's difficult to get this data, but it's always around 20%, except in Korea, it's now at 50%. In Japan, I saw yesterday, they published something that 43% of their cases were being done laparoscopically. But if you turn the world upside down, really ask that question, it means that over 70% of cases in the world of colon resections are being done laparoscopically. And you have to ask yourself, why is that? So where do we stand? What are the figures now? What is the better operation? And what are the questions that are left? And so this is a quote from Schopenhauer, a German philosopher. All truth goes through three phases. First, it's ridiculed. We all live through that. Then it's violently opposed. We live through that too. And thirdly, it's accepted as being self-evident, which is where I think we are now. The timeline is what we're going to look at. And this was really the big thing. The cost trial got us over the hurdle laparoscopically for cancer. But where are we going to go? So what's going on today? This is what I would say is the questions that I wanted to address. And so this is data that David Schatz was nice enough to share with us from the American Board of Colorectal Surgery. And so it showed 41% in the training programs in the States, 41% of the colon resections are being done laparoscopically for cancer, 45% for diverticular disease. Overall abdominal surgery, about a quarter are being done laparoscopically. But when you look at that data, you have to understand that these are the bigger, more interesting cases that the fellows are gravitating towards. It's not a true representation in terms of incidence, more likely. And it also, as a point, it doesn't differentiate the hand assist from not. And in a similar time period, in a nationwide database published in Surgical Endoscopy, still only 5 to 8%. So why is it? What are the attitudes that are driving this? Is it patient-driven? Is it surgeon-driven to still do things laparoscopically? Well, if we look at some of the stuff in the literature, looking at surgeons performing laparoscopic colorectal surgery, if you ask them why they're not doing more, most of it has to do with OR time, no problems with facilities, and patient factors, which I can only assume to mean the patient's too heavy or too much, too many previous surgery. If you talk to surgeons who are doing open surgery, they said that training was an issue, OR time was an issue, but it's interesting that when they were polled, 16%, only 16% of the people thought that laparoscopic colon surgery was not better. 52 to 84% recognized laparoscopic colon surgery was better in terms of colectomy. So it begs the question, why not more? And really the things that were identified were lack of formal training and inadequate operating times were the major obstacles that surgeons quoted. So this is just the data in terms of where things stand. This is something that Connor Delaney had published. 33%, this was from 2008, 33% of cases being done laparoscopically. And you look in terms of this whole list of outcomes, comparing open to laparoscopic, what we find, that was morbidities, this is length of stay. The summary of all this and the date of discharge, the summary of all this is while this is absolutely a big national database, it's not perfect, was that laparoscopy was better. Patients were in terms of less transfusion, less readmissions, less overall complications, less ileus, less wound infection, less cardiopulmonary issues, and a shorter length of stay is on the laparoscopic side. What comes up better for the open side is a $400 cost saving, a 17-minute less OR time, and statistically significant decrease for less reoperations, 0.3% versus 0.5%. So this is another look at what's going on. This is a big retrospective analysis looking at wound infection rates, and what they found is that in the laparoscopic group, now this is not specifically for colorectal, but overall clearly a benefit in terms of wound infection rates and in terms of things being done laparoscopically. From an oncologic standpoint, we're all familiar with Antonio Lacey's data. they actually showed a cancer-specific survival benefit in that group. And they concluded in 2002 that this was beneficial, which caused a bit of an eye-popping realization or consideration. Larry Whalen had looked into the biological aspect of this and found that tumors are growing more readily in laparotomy mice than laparoscopic mice, and that's what this looked like. These are the lungs in terms of metastatic disease burden after laparotomy compared to laparoscopy, compared to sham. And then he's followed this up with some significant basic science research. He presented some of that this meeting and showed really that VEGF was elevated much longer in open surgery compared to laparoscopic surgery. And so there might be a biological basis for this, a real measurable basis from going on. The cost trial we're all familiar with, an improvement in terms of all these issues, 20% longer hospitalization in the open group, a third more IV narcotics and 100% more oral narcotics, improved quality of life after laparoscopy in the early parameters compared to open surgery. In terms of morbidity and mortality, no difference. Local recurrence, no difference. Survival, no difference. So where did that put us? In summary, from that study, and I think this goes without question now, it's accepted. Outcomes are fine. Safety is fine. The patients have related benefits, and we concluded that there are no compelling reasons not to offer laparoscopic colectomy to appropriately selected cancer patients. Now, this is 2004, and I might say that that's kind of the conclusion of the double negative, and in 2011, we might ask the question, there are no reasons to withhold laparoscopic colectomy to appropriately selected patients with colon cancer. And so the caveat is I think this always needs to be discussed in this day and age with patients as an option. Lap rectal surgery, really the Mount Everest or the Mount Fuji of laparoscopic surgery. There is no level 1A evidence in looking at things laparoscopically. This is a Cochrane review, goes over this. No difference in terms of mortality, morbidity. There's a benefit in terms of blood loss for the laparoscopic group in rectal case, no difference in terms of pathologic outcomes, no difference in terms of survival rates, and so no difference in terms of local recurrence. And so this is under trial in Europe. The Color 2 trial should be concluding shortly. In the States, the ACOSOG Z6051 trial is accruing nicely, and hopefully within the next 24 months, we'll have some data in that regard. This is basically a trial just looking, it's like the cost trial, but for rectal surgery. And so, in conclusion, if we start to look at what is the next big thing, I think instead of this being a leap of faith, this is really us building the bridge across to laparoscopic surgery. And if we think back about the tipping point, the event in which something previously rare becomes a dramatically more common phenomenon, I submit to you that we should be there for laparoscopic colon surgery. Frederick Douglass said, if there is no struggle, there is no progress. And I think we have to ask ourselves as organized medicine, is there a problem with the vehicle, with the airplane? Is it an airplane problem, or is it the pilot problem? We have to address this for our surgeons so that the surgeons can offer this to the patients. Is it ethical or acceptable for us to promote an operation that has more pain, a longer hospitalization, a longer full recovery, more early and late complications, more blood loss, more transfusions being needed, no advantage in terms of long-term outcome, and worse cosmesis? If you look at it that way, it really raises the question, is it ethical to not discuss, do we need to document for patients why is something being done open as opposed to laparoscopically in this day and age? I would submit to you that we, as surgeons and as leaders in the field, should be finishing the job and getting us over the 30 to 40% range and into the 70 and 80% range. It's going to take education, addressing attitudes of those who are resistant to it, and state plainly, I think, that in this day and age, really obviously not for everyone, but I think that all things being equal, laparoscopic surgery should be the standard against which colon surgery is measured for. So I think that with cosmetic differences such as this, the patients are going to ask for it, and it's going to be a better place for our patients, and the referring doctors are going to be insisting upon it as well. So I thought I'd put that out there to start the session, and I'm happy that, and I hope that this engenders some conversation. Thank you.